Hi class and Dr. Mates, welcome to my case study. Today I'll be discussing a case study about a squamous cell carcinoma on the lower lip. This is a super fun and personal topic for me because prior to this program I worked in a dermatology office and I was the first assist for our Mohs surgeon, so I got to actively participate in repairs on the lips and other areas of the face, back of the hands, just like the one I'm about to outline. So I did that all the time, so let's get started. You guys probably are wondering what is squamous cell. So before I dive straight into the case, let's do a little SCC overview. So first of all, squamous cell carcinoma, also as I will refer to here on out as SCC. It is a type of cancer and it does target our epithelial cells. So skin is super common, mouth mucosa, and less common but still can happen would be like throat squamous cell cancer or even like SCC of the anal canal. So causes of lip SCC. Sun exposure is a big one. Tobacco use, yes. Vaping counts. I did actually find a different case study where this 19-year-old did pass away, which they contribute to vaping of the SCC of his tongue. Also heavy alcohol use. And HPV. Go back to the case study. This is highlighted here in case you wanted to reference that. How aggressive is SCC? So a lot of patients that I used to deal with, stage 1, stage 2, stage 3. Typically, if you are being treated by a dermatologist for Mohs surgery, this would be, 0 to 1. If you're referring you to oncology, that means it's already spread. So this in this case would probably be like a stage 1 or so. But yes, it can metastasize. So you do have to take care of your squamous cells if you ever are diagnosed. And treatment is typically surgery. There are a few other options for you like radiation or cryotherapy, but typically it is surgery. So if you have a squamous cell, surgery it is. Okay, audience present. So it wasn't indicated in the case study, but we can just take an educated guess. So for this initial appointment where maybe she's like, I had the squamous cell, or eventually we'll find out is a squamous cell, will be the dermatologist or dermatology advanced practice practitioner, APP. There'll be a medical scribe, maybe a family member, close friend. As always, there's a possibility of an interpreter. And then for the follow-up surgical appointments, it'll be obviously the Mohs surgeon. It's either the surgeon who did the biopsy or they were referred to Mohs. 1 to 2 MAs or nurses that will be assisting the surgeon. And then there will, many of the times the patient will bring a family member, a close friend, but for surgery, they stay out of the room. So they'll be in the waiting room for the duration of the surgery. All right, let's get started. So the case study, the patient history, she's a 67-year-old woman. There's a large growth on her lower left lip. The site history was previously biopsied 3 years ago, and we found it to be PCM, which is plasma cell cheilitis. It's a benign inflammatory condition. The PCM was then injected with TAC, triamcinolone, and went away and considered to be resolved. But then she said about a year after the injection, growth on the lower lip started to return, and she hasn't come back to the dermatologist since. So the growth has been enlarging for the last 2 years. And this is it. Yeah. Ooh, ouch. Physical exam. Large ulcerated plaque on the lower left lip. It was 3.8 by 0.8 centimeters, and so immediately the dermatologist, suspicious, did a biopsy. And after we do biopsies, it's about a 1 to 2 weeks to wait for the results. In the meantime, the patient has to hang out. But basically the biopsy will be sent off to a dermatopathologist after that. It'll be reviewed. The dermatopathologist will come to a diagnosis, which is then sent over to the biopsying clinician. The clinician will say, yes, that makes sense, or no, that doesn't make sense. And then a treatment plan by the biopsying clinician will be made. And then if the clinician, like I said, is already a Mohs surgeon, then they'll set them on their schedule. If not, a referral has to be placed. So that's all what happens within the 1 to 2 weeks while this patient waits for their biopsy results. So yes, as we expected, the diagnosis comes in, and it is a squamous cell carcinoma of the lower lip. So the treatment plan would be Mohs surgery. This means that it had no pleural invasion, so it hasn't spread through the skin into, let's say, the muscle or anything, or at least the biopsy didn't suspect that. So Mohs surgery it is, so she will be scheduled, and typically these are done within 1 to 3 months is kind of pushing it, but for her, especially being on the lip, we'll probably want to see her as soon as possible. as possible for Mohs surgery. So what is Mohs? Mohs is a tissue-sparing procedure indicated for geometrically complicated or cosmetically sensitive areas. So it's indicated for face, lips, scalp, the back of the hands, shins are common. It is also a staged procedure. So essentially the tumor is visualized and the Mohs surgeon will cut out just what they think the tumor is. And then they'll take the tissue out, it'll be processed into a microscope slide, and then the surgeon will read that microscope slide. And then the stages will continue until we have clear margins, so no more skin cancer or patient fatigue. More often than not, you get clear margins. Every once in a while, people get tired and they want to go home and they'll finish it later. So for this patient's case study, the goals in the case study were to keeping normal contour of the lip, not shrinking the mouth, maintaining functionality of speaking, breathing, eating. Just even in this presentation, imagine how many times my mouth has moved. And then finally, a non-deforming cosmetic outcome. So anytime you manipulate the skin, you're going to get a scar. There's no such thing as a non-scarring procedure. However, you can have and maintain a goal to have a non-deforming cosmetic outcome. So what we are seeing here now is after Mohs, okay? So she's undergone Mohs, she took 3 stages, and this is the final defect. So there is no more skin cancer on her left lower lip, no more squamous cell. However, this is the final defect. So you can see that it involves the entire thickness of the lip. They took the whole lower lip there, and the final defect was pretty large. It's 4.8 by 1.8 centimeters. So now the magic of a Mohs surgeon is, what are they gonna do to put this back together? So the magic is going to be the Mohs repair. So the flap that was chosen, let me back up a little bit. There are many different ways up the mountain, as I like to say, for Mohs repairs, but in this case, a flap was chosen due to its size and the inclusion of like the vermilion border and the lip itself and the surrounding tissue. So the Abe flap was chosen, which is a W-shaped flap. As we can see here, there's kind of this W here and this M on top. And what we're going to do is we're going to take this upper lip here and we're going to translocate it onto the lower lip. So if you see this M here in the dark purple, this point is actually going to be this point when it's all said and done. And this point here is going to be this point. So this M turns around and becomes this W. This dotted line here, that's where the undermining will take place. Typically we need to make the skin more elastic, so same thing here, dotted line here, more undermining. There's a couple more marks over here, purple pen. That is because when the lip of the upper lip then becomes the lower lip, it won't be able to reach all the way over to this medial border, so there's a little bit more manipulation that will occur right here. But the idea is this whole upper lip is becoming the lower lip. So yes, this is the middle now of the Mohs surgery. You can kind of see this M portion up here that we no longer can see actually. This triangle is going down into where this triangle is. We can imagine this is the part, and then this part of the M is going down into this part of the W. We can imagine that here, and then some of the undermining, this needs to be closed, so it looks like they had started that with the deeps, and then they're going to sew this part of the upper lip now onto the lower lip in this W shape. As I was mentioning earlier, this is still exposed slightly, and there's a little bit extra surgery that needs to be done so that this hole will also be closed as well. Okay, so that is this. Next and finally, sew everything together. So once the Abe flap was successfully rotated from the upper lip to the lower lip, she's all fixed up. So once again, this M up here became this W down here, the upper lip became the lower lip, then we had a little bit of repair here, and then that medial portion that I mentioned in the last slide is now also has had some manipulation and has been slid this way, medial. So yes, this entire repair was then has 3 layers of stitches. So you're going to have your base layer underneath the dermis, kind of in the fat, and then you're going to have your dermal stitches and then your superficial epidermal stitches, what we see on top here. Okay, first Mohs follow-up. About 3 weeks later, the final defect size was not given, so I can't say about how large this is. Also, I'm so sorry, the picture that they provided is not the best. But here we can kind of imagine where this W is here and that little Y that was up here as well. But good news, the flap didn't die. The stitches were removed, the epidermal stitches. The interior stitches will likely dissolve over the next 1 to 2 months. And the patient reported minimal post-op complications. She reported little to no bleeding. There was no flap necrosis, no infection. However, the one thing that she has experienced is still there's a bunch of numbness in the area, which is pretty expected. There's so many nerves that innervate the face, especially the lips, that numbness, it will take a while for those nerves to regenerate. Sometimes they can be as numb as for a couple months to even a year, but most of it should be coming back in these first couple weeks. Okay, so this is her second Mohs follow-up, 3 months after the Mohs repair. Her lips are in good condition. You can kind of see this W scar here a little bit, but it's pretty good on the top. I think maybe this picture's a little bit washed out. I was assuming there would be maybe a little bit of that Y you could see there. The lips look pretty good. So yeah, the scar's present, but it's not deforming, which was one of the goals. The patient reported no sequelae of oral incompetence after surgery, so that means she's maintained function and eating and speaking, and overall she said she was happy with the final outcome. So this was a huge improvement for her. If you recall the very first picture, she had that giant ulcerated, black necrotic, patch there or papule there that just looked very uncomfortable. So this is a much better outcome for her. So this concludes the case study of the squamous cell of the lower lip. So in terms of analysis, my overall takeaway was that this was a good case study. I mean, this was one of the reasons why I selected this case study, because I found it interesting and I thought I had a lot of good pertinent details that I would expect from, a review of, a complex repair of this nature. There was a detailed history about maybe why the patient took so long to come back in, because she thought it was something else. Side note, it should be noted that the original diagnosis, that benign inflammatory condition, does not cause squamous cell. I think it's just a coincidence that the happened in the same spot. I mean, the lower lip is so subject to sunshine, especially if she had a history of tobacco use, which it didn't mention, but maybe she did. Very common area to get squamous cell carcinoma is the lower lip. And then what I was most impressed about, however, though, was the details about how the repair was performed. So it talked in length about how there was the 100-degree rotation, and how the upper part of the lip became the lower part of the lip, and there's this W scar, and all the above. However, this was a good case study, but there are a few areas of improvements that I would recommend. If this group had written another one, I would like more pictures. Dermatology is a very, very visual field of medicine, and so you can never go wrong with having more pictures. And so when I was in practice, the dermatologist wanted us to take pictures of every stage, and she had 3 stages, so where are those 3 extra pictures? There was that one picture at her first follow-up that wasn't very good quality, so we need better quality photos. And then finally, I would have liked maybe a 1-year follow-up on the patient to just make sure that she maintained function in the lip, and then that maybe the numbness stopped being so numb and she had the feeling returned. A 1-year post-op of the scar would have been nice. So those are the improvements that I would suggest for this case study. But overall, I think it was a good case study. So quickly, I just wanted to talk about maybe a different repair option. As I mentioned earlier, there are many paths up the mountain when you repair a Mohs site. So this is just another flap. So this is called a mucosal perforator flap. This here, so this here, it was a much smaller defect. If you recall the lady, her whole entire lip was kind of taken out. For this gentleman, he just has a smaller final defect, but the idea is that this is now that purple line that I mentioned in the other case. This is going to be cut and undermined, and this is them halfway through where it is cut and undermined, and then it is pulled, here, let me get one of these things, and it's pulled in this direction over. So the lip is actually getting pulled in this direction, and then it is sewed. And boop, right there, and then he now has a lower lip again. Okay, last thing I want to touch on is the additional considerations for rural to low income patients. So first thing first, Mohs surgery is very specialized. They're dermatologists, but they also do an extra year of fellowship. So not every dermatologist is a Mohs surgeon. So if you're living in a rural area, you will very likely have to travel somewhere more populated to find this specialized doctor. Surgery in general is expensive. So you're paying for the skill set of that surgeon. You're also paying for the facility, and you're also paying for people like me who were trained to assist in the surgery itself. So if you're low income or have a high deductible or don't have insurance, this is going to be a very expensive operation for you. Back to rural patients, follow-up is important. After you're diagnosed with a non-melanoma skin cancer, typically you would be seen once a year by your dermatologist. So if you live hours away, you are now making a day out of the year where you have to drive into town, and that can add up over the years. Another thing for low-income patients is insurance might not cover the surgical repair if the final defect is too large. I know it's so dumb, but I've encountered a few times where the skin cancer, let's say it's on the cheek, ended up being bigger than we expected, and and the insurance was like, oh, this wasn't part of the referral, like we're not covering it. And then now you have this poor patient with this huge skin cancer that was just taken out of their face, and they're like, my insurance is not covering it, and I'm frustrated because I have to do extra paperwork, and the surgeon's frustrated. Everybody's just upset, and it's taxing on all individuals. So that happens. And then finally, another thing for low-income patients is paying out of pocket for supplies to care for their own post-op wound care. So at least in my office, we would start them with a goodie bag, as we called it, with some Band-Aids and Vaseline and some Q-tips and CTAs and stuff like that. But I mean, between the biopsy site itself and then the Mohs surgery and then, taking care of the spot for at least 2 to 3 weeks after, like maybe your little goodie bag, if you have a big spot, is not going to, propel you all the way through that journey of yours, and you're gonna have to start paying out of pocket for medical supplies. So that's another consideration for rural to low income patients. So all in all, if you're a rural or a low income patient, you do have extra barriers that you do have to overcome in order to get adequate care, which is an unfortunate reality, but it is a reality that I encountered, and it is definitely a consideration. Okay, that concludes my case study of squamous cell carcinoma of the lower lip. Today we learned some pretty cool stuff, mainly just detailing the Mohs surgery and the Mohs repair and the outcomes for, what happens when you get skin cancer on your lip. And we also discussed what I liked about the case study, what I didn't like about the case study. We went over an additional flap that could be a possibility. And we also discussed considerations for low income and rural patients. So all in all, I hope you enjoyed this case study. I did include a lot of pictures, so hopefully that kept your attention up until the end. If there are any questions at all, or if you have any interest in dermatology just in general, please feel free to reach out. I'd be happy to chat. See you guys on Canvas. Bye.